welcome to our final lecture. Okay? Crazy? It feels like holiday season out there, doesn't it? Unless you don't like the cold. Okay, so we're going to talk at the very end here about cardiovascular disease, and I promise we'll see inflammation rear its head yet again. Okay? So first up, this is what I'd like you to do. I would like you to think about studying this fashion as you're thinking about these disease states as they relate to the heart. So I want you to draw a simplified picture of the heart and label the following. Right ventricle, right atrium, left atrium. I want you to do it right now. Done with that, go ahead and draw the flow of blood flow. Oh, snap. Which way does it go? Where does it come in? Where does it move? It leaves the heart twice. It goes arteries away. I like it. That's good. Okay, you guys, is this dusty cobwebs? Are these dusty cobwebs a little bit? Okay, this is 202. Okay. How many of you heart looks like this? Huh? Oh, look at you. Oh, okay. Well, oh man, draw. But that's a pretty good heart, huh? That was a fairly sexist comment, I apologize. But we're just going to make a box. Okay? What's that? It doesn't look like that, but from an engineering standpoint, this will work just fine. Okay, so right side of the heart, what is this? Right atrium. Right side of the heart? Right ventricle. Left side of the heart? Left atrium. Left ventricle. Okay. Where does the blood come in? Right atrium. Right? So it comes in here. What structure brings it in? So it's superior vena cava and inferior vena cava. You with me? The blood that flows this way is what we know as venous return. Then it comes through what valve? What's that? Tricuspid. And then it leaves the right ventricle and goes where? Lungs. This goes to the lungs. And then from the lungs it comes in where? This pen is in. There we go. And what vessel brings it? What vessel takes it away? Pulmonary artery and pulmonary vein. And then where does it go? Also known as mitral. And then leaves the heart. Correct? And what is this vessel? Aorta. Okay? And here, this is cardiac output. So we have venous return, and we have cardiac output. Okay? You guys with me? Not really? That was an honest answer. So that's like 202, like a week of 202 in 2 minutes, right? But this flow is going to be really important because we know that we've got a right side and a left side of the heart. And my box diagram is shown here, but in greater detail by some artiste, right? Which I am not. Although I drew a pretty wicked heart, don't you guys think? That's pretty good. So, anybody can draw this box. You want to put this on your exam to help guide you on what side of the heart we're on, where we're thinking about, coming from, going to. Because the types of heart diseases that we're going to cover are the ones that are in black text. And even though I shortened this lecture for the sake of time, we were never planning on covering the bottom 3. Okay, it's general pathology. We're not going to be able to go through all of them, so I had always planned on doing 3 out of 6. That was on the original slides too. We're going to talk about kind of the 3 biggies: congestive heart disease, arteriosclerosis, and ischemic heart disease. A close third, though, is valvular heart disease. And the 2 main valves that are affected are either the bicuspid or the aortic valve, which is shown right there. Right here. Right. And now we're doing minimally invasive aortic valve replacement. It's not yet mitral valve, but we are doing minimally invasive aortic valve. So this is a great study tool to kind of help explain to you or remind you of where we are in the heart and how different parameters might be affected. So here in a moment, we're going to be talking about venous return, we're going to be talking about cardiac output, and we're going to actually be dividing the heart into right and left sides when we talk about disease. So the 3 biggies, the first one of the 3 biggies is congestive heart failure, okay, CHF. So congestive heart failure is usually a systolic problem, right? So if you remember, systole is when the heart contracts or is compressed. It's under compression, so it's pressurizing the blood so that it can exit out. So you get flow when you have a difference in pressure. You guys understand? So if you pressurize a tube on this side, you have high pressure here, you have low pressure here, so it's going to go from high to low. So the way that we get blood flow is we pressurize the blood by contracting the heart. That creates a high pressure. Downstream is low pressure. It moves from high to low. So it's usually a systolic problem, meaning it's usually a pump failure problem. 2 main causes: endocarditis, okay, so an inflammatory disease of the endocardium, or abnormal load. And now, in our Western world, the abnormal load is starting to take over. When I say abnormal load, I'm actually talking about hypertension. I'm talking about high blood pressure. That's what hypertension is. Why is that an abnormal load? Well, we'll talk about that here in a quick second, but the load that the heart as a pump is seeing is higher when you have high blood pressure. It has to pump against a higher load. So you have what we call forward failure, meaning you decrease the cardiac output here if you cannot work as efficiently. So, for example, if the blood pressure, mean arterial pressure within the aorta, let's say it's sitting at 100 millimeters of mercury, mean arterial pressure. What pressure does the left side of the heart have to achieve in order for flow to occur? What minimum pressure in millimeters of mercury does the heart have to achieve? What's that? 101, right? If it's 100 and it's 100, is there any flow? If it's 101 and 100, is there flow? If it's 105 and 100, is there more flow? If it's 120 and 100, is there more flow? What if it's 120 and it's 80? Is the heart working less hard? Yeah. It's very simple, right? So if you have hypertension you have a higher load that the heart has to pressurize above in order to open this aortic valve and actually eject blood. So high blood pressure causes the heart to work harder. High blood pressure causes the heart to work harder, and it subsequently decreases cardiac output. You guys with me? Okay. So, good news. Well, and some bad news. But the good news is the heart tries to compensate. It really does this in three ways. It does this first by increasing norepinephrine. Secondly, utilizing the renin-angiotensin system. And thirdly, releasing a factor known as ANP. So, we'll talk about each one of these three on this slide. So first, and very quickly, the heart releases the body releases norepinephrine. Okay, it comes from the adrenal glands, the adrenal medulla. And norepinephrine is known as noradrenaline. Okay? Very similar in physiologic activity as adrenaline. So what does it do to activity of the heart? You wake up in the middle of the night and that stupid battery needs to be changed in your smoke alarm, right? The norepinephrine is released, and what happens to your heart? Like, right? Or a phone rings, somebody rings the doorbell, right? So norepinephrine almost instantaneously increases contractility. So contractility is the force at which the heart beats. The heart beats like in a ringing motion. So have you ever taken a towel, like a washcloth, and you soak it with water, and then just squeeze it like this, just circumferentially squeeze it, okay? Then do it again, but wring it out. You'll get way more water out of the washcloth if it's a ringing motion. So the heart actually pumps in kind of a ringing type of motion. So it minimizes the amount of leftover fluid inside of the chamber, making it more efficient, okay? So increasing contractility, it's as if you wring out that washcloth more forcefully, okay? So you can wring it out, have my kid do it, my 9-year-old wring it out, and then I can do it, we're gonna get different results, right? So if you more forcefully wring out that washcloth, you'll get more fluid. If you more forcefully contract the heart, you're gonna get more blood flow out, okay? But negatively, this actually increases our total peripheral resistance over time. So total peripheral resistance, that norepinephrine actually causes constriction in the vasculature out in the body. And so that actually lowers total peripheral resistance. And that has an effect of decreasing venous return. Okay? If you increase resistance in the vasculature, you lower venous return. So, if I lower venous return, I get less going in, which means less comes out. And that relationship is known as the Frank-Starling law of the heart. You guys remember that from 202? More in means more out. Also, less in means less out. So, over time, you have an increase in total peripheral resistance, and you have a subsequent decrease in venous return. And that ultimately leads to a decrease in cardiac output. So that early response, number one, of increasing contractility when the heart is pumping against a higher load is a temporary fix, but it doesn't last for the long haul. Next, we activate the renin-angiotensin system. So if you recall, the renin-angiotensin system, we've got angiotensin converting enzyme, takes angiotensin 1 to angiotensin 2. That increases your thirst centers. You usually consume more water. And by consuming more water and by having the renin activity at the kidneys, you don't excrete it out, you increase your blood volume, right? If you increase your blood volume, you increase more venous return. That comes here and increases cardiac output, right? That's a good thing, right? What's the bad news about having higher blood volume? after you've increased your cardiac output. If your heart is already working against an abnormal load. What does a higher blood volume do to blood pressure? It increases it. So if the patient's already hypertensive and you increase the blood volume, it makes them more hypertensive, right? And now the heart has to work even harder. So the renin-angiotensin activation helps temporarily, like increasing contractility, but over time, it's not going to be able to fix the problem. So what are we talking about as time frame? So the first two might happen for days, weeks, to maybe a year or two. Then the patient is out of options, and in the next year or two, we utilize the third option, which is ANP release. ANP stands for atrial natriuretic peptide. It comes from the atrium. And this atrial natriuretic peptide stimulates natriuresis. This is excreting sodium in the urine. And if you increase sodium excretion, what does water do? It follows sodium, and so you pee out, you urinate out more water, lowering blood volume. If you lower blood volume, what does that do to your hypertensive patient? It lowers their blood pressure, and now the heart has to work less hard. So the third one is actually pretty beneficial for a mid-range time frame. But once you've done the third option, you're out of options. Okay? So the first two last for days, weeks, or days, months, to a year or two. The third option, ANP, lasts for maybe a couple of years. If the patient's symptoms continue and they have other heart problems that show up, there's no more compensatory mechanisms to take place. So what we have is, with heart failure, we've got this inability or a mismatch of the heart having to work too hard to overcome the blood pressure, the mean arterial pressure in the system. And the mechanisms that we talked about work for an early amount of time, but they aren't going to last for the lifetime of the patient. They're not going to last 10 to 20 years. Okay? Okay. Yeah, so cardiac cachia. So the Frank-Starling law of the heart is, you increase venous return, you put more into the heart, you're going to increase cardiac output in future heartbeats, because more inflow leads to more outflow. And so the heart's going to try to compensate as best it can. It compensates and then it decompensates, right? Option one works for a little while, and you got to go to option two with the renin-angiotensin system. And then ultimately you're down to ANP. And once you're out of those options, now you start progressing into what's called heart failure. Heart failure is clinically determined or defined as an ejection fraction that's less than 40%. 40% or less. Equal to or less than 40%. Typical ejection fractions are about 75%. So the heart as a pump is actually only 75% efficient. So what that means is, if 5 liters goes into the blood of venous return, only 75% of it leaves, and 25% of that 5 liters is actually remaining. So let's use simple math. 4 liters go in, 3 liters leave, 1 liter stays in. That's a normal heart. 40% EF, or ejection fraction, means if 4 liters go in, right, more than 2 liters is actually staying in the heart. You with me? That's defined as heart failure. Now the heart's working extra hard to try to keep up with life for this patient, and because it's a muscle and it's working harder, right, and you have somewhere between 60 to 100 beats a minute, depending upon what you're doing that day, that's a lot of exercise. And so the patients that are in heart failure oftentimes will start losing severe amounts of weight, known as cardiac cachia, because the heart itself is working so hard and exercising on a regular basis, that it's burning up all the calories. Yes?
With AMP, how does it fail exactly?
How does it fail?
Yes, because you said that it would release more fluids.
Yeah, so
Hypertension.
how does AMP fail as an option? Well, the atrial natriuretic peptide, right, will stimulate urine outflow, and you'll drop your blood pressure. But if the heart has been failing for a long period of time, and we're going to get to this later in the lecture, if there was a myocardial infarction, like a heart attack, and there was an area of the heart that was damaged, and that's the reason it's working less efficiently. As that disease progresses, you can't release more AMP. I mean, you can't pee out all your blood volume. You need some blood volume there to operate. So there's a threshold at which, and you can't excrete all your sodium. You actually need your sodium too.
Where's the release from? Where's it?
From the atrium. Yeah. Okay. So we're going to do compare and contrast left-sided versus right-sided heart failure. So left-sided heart failure, maybe as the term suggests, is really influencing the left side of the heart. Things that will cause left-sided heart failure are going to be ischemic heart disease. Okay? Blood flow to the heart is compromised, so now the heart's working less efficiently. Kind of like we just talked about with that question. Systemic hypertension, like we've introduced in the very beginning with the mean arterial pressure example. If you have a mitral valve or aortic valve disease, the mitral valve, the bicuspid, or the aortic valve, if they don't close completely and you get regurgitation, you get fluid going in the opposite retrograde direction, it's working less efficiently. So that can lead to congestive heart failure or chronic heart failure. So congestive heart failure, chronic heart failure, depending upon what papers you're reading, they're both abbreviated CHF. Some refer to this as congestive heart failure, some call it chronic heart failure. I want to compare and contrast the two here in a second, but they're really referring to the same thing. Okay? Chronic just means long term, and congestive is talking about the fluid that builds up. And I'll talk about this, the fluid that builds up in the lung here in just a second. So we also could have myocardial disease itself of the heart, like a genetic abnormality of the working muscle. That could cause left-sided heart failure. What's the output? Well, the heart itself enlarges, hypertrophy. The heart itself enlarges. And maybe this is where you were wondering about with cardiac capnia. So enlarged heart syndrome, right, can show up in certain populations all by itself as a genetic abnormality. So some of you have heard of these, like I think unfortunately it's mostly basketball players. These even NBA level basketball players will pass out on the court and die of like a ruptured heart or enlarged heart because of this hypertrophy. They didn't realize they were in heart failure. It can also happen with bodybuilders, okay, enlarged heart, especially bodybuilders that are looking at using or have had a history of using anabolic steroids. The ventricle itself dilates on the left side, and then you get pulmonary congestion because, look at my diagram, if I cannot, on the left side, push the fluid out and a lot gets backed up inside, my ejection fraction is 40%, so I got greater than 2 liters of the 4 liters that are sitting in the heart. Where does it back up to? The lungs, right? So you get pulmonary congestion. You get a lot of fluid in the lungs. It's very uncomfortable to breathe. Patients will tell you it feels like somebody's sitting on their chest while they're trying to take a breath. So those of you that are going to be nurses or physicians or taking care of patient populations, if you have a congestive heart failure or chronic heart failure patient, they will tell you, oh my gosh, it's so hard to take a deep breath. That's because of all the fluid that's backing up into the pulmonary side of the network.
So, like a chronic cough kind of be associated with it, maybe?
A what?
Chronic cough.
Yeah, so you'd have a chronic cough. That's exactly right. So in these patients, we will prescribe, one of the first lines of defense is we prescribe diuretics, like to do more than what A&P will do. A diuretic to cause them to urinate more frequently, and that lowers their blood volume and they tell you, they'll say, oh my gosh, it feels so much easier to breathe. It's kind of, again, like A&P, it's a temporary fix. Okay?
So the fluids are backed up in the lungs, or
Yes.
backed up
In the venous, it's in the vasculature of the lungs, but because the lung vasculature now is pressurized, it leaves the bloodstream and it goes into the parenchymal tissue of the lung. So, there you go. Cough is definitely one of the symptoms. Shortness of breath, that's dyspnea. Shortness of breath. Orthopnea, that's shortness of breath while lying down. Tachycardia, where the heart is at a higher heart rate. Mitral regurgitation, that's the bicuspid valve, or atrial fib. Okay? All of the symptoms of left-sided congestive heart failure. What about right side? Okay, so that's on this side, the left side of the heart, backing up to the lungs. On the right side, if it backs up here, where does it go? Where does it go? To the vena cava, back to the body, right? So its backup is into the system, the systemic circuit. On the venous side, what's a large organ that's fed by venous blood flow? Where do we just come from? The liver, right? So now you have congestive liver disease because you get portal hypertension on the right side. Because this venous return gets backed up, and any organ that's on the venous side of the circulation that's being fed, aka the liver, you're going to get congestive enlarged liver, hematomegaly. Okay, that's congestive enlarged liver. You'll get pleural effusions, and you'll get peripheral edema. So, the most common cause of right-sided is a left side backup. Because if it backs up to the lungs, what's downstream from the lungs? The right side. What's downstream from the right side? The system. And then primarily the organ that's going to be affected is the liver. Some of the other causes, though, if it's not left-sided heart failure, could be things like a lung disease, like a lung cancer, okay, a lung tumor, or lung vascular diseases. Because if the disease starts here in the lung and it backs it up to the right side, that could be independent of what's happening on the left. Make sense? So we've just compared and contrast left-sided heart failure versus right-sided heart failure. Because they're connected, left-sided heart failure can lead to right-sided heart failure. Do you understand? Questions?
So when the left ventricle is congested, it will backflow to the left side atrium, which puts the lungs, which affects the right ventricle.
Correct. That's correct. That's why we have this diagram, right? Just to kind of help us. So if it's a left-sided problem, right, left-sided heart failure, it'll back up to the lungs. If it continues and the lungs continue to get backed up, you're going to end up with right-sided heart failure, which could put pressure on to the system and end up with liver enlargement, right, and portal hypertension.
But aren't the valves there to stop it?
What valves?
The valves that don't allow that.
On the venous side?
Yes.
Those are found in the distal extremities.
So they're not valves.
They're not in the vena cava or in the central system. They're down here in the legs.
So if somebody were to die, have left ventricular hypertrophy, could they theoretically die from any of the impacts of the system? Automatically.
Yes. Yeah. Yeah. So the question is, if somebody had, can I rephrase so they can hear in the back? if somebody has left-sided heart failure, could they die of one of these downstream problems, like liver failure? Yeah, of course. I mean, it may be if they have left-sided heart failure, they're going to have a heart attack before the liver goes out. But they could have a liver problem that takes them. Yeah. Okay? So they're all connected. Right, so it wasn't the end of the world last week when we didn't get the liver, because it actually ties into this lecture just fine. Okay? Other questions? Left versus right-sided heart failure. You feel comfortable that you can compare and contrast the two? You can talk about what causes what. You can talk about what results from which. Right? So congestive heart failure, it gets its word congestive because of the backup in the lungs. You get a lot of lung congestion. Chronic heart failure, it gets that terminology because we're talking about long-term, chronic instead of acute. Chronic heart failure, where the heart, over a long period of time, is compromised. Okay? Clear? All right, just want to make sure we're not going too fast. Our second topic, arteriosclerosis. So arteriosclerosis, we alluded to throughout the semester. Right? We've talked about disease like in the kidney vasculature. I've talked about disease throughout the vessels associated with like type 2 diabetes that's unmanaged. You guys remember that? We talked about vessel damage with type 2 diabetes. Type 2 diabetes is on this exam, right? Diabetes mellitus type 2. That's where we started. So we started with this new material with type 2 diabetes mellitus, and one of the clinical sequelae of unmanaged type 2 diabetics is vascular disease, in this category of arteriosclerosis. Okay, so we're kind of bookending this third, not chapter, but segment of the class. Okay? So, what happens in the vasculature if it's damaged? And the blood vessels are made up very intricately of 3 layers. You can see that in the upper right. So you've got the innermost layer of the tube. So if you take the blood vessel and you're looking down the end, the inner lining is known as the tunica intima. Right? The tunica intima. The other name for it is the endothelial layer, because the layer that's the innermost lining is a single monolayer of endothelium. Tunic is a Latin word that means covering or coat. Right? Most of you had a tunic today. When you left your house, you put on your tunic before you walked out. Wouldn't it be fun if we talked like that? Okay. Yo, give me my hoodie, right? So, tunica intima is just inner coat or layer, covering. Okay? Tunica media is where the smooth muscles are, and the tunica adventitia is the outermost coat or the outermost covering. Now you can see that the tunica media is circumscribed, or it's bordered by 2 layers of elastin. You have an internal elastic lamina and you have an external elastic lamina. And they divide, they cut off where those 3 boundaries are by those elastic layers. That's normal. Okay? Now if you've got a damage to this vessel, you expect to see things very similar to other types of healing. You're going to see a healing response. You're going to see inflammation. You're even going to see fibrosis that takes place. Okay? So, what happens when that gets damaged, though, is we lose the ability for the vessel to respond. Because that endothelial layer, this endothelium, is an anti-thrombogenic layer. That's what it's there for. It prevents clotting. That's why it's there. It's the innermost blood contacting surface that has an anti-thrombogenic property to it so that your blood doesn't spontaneously clot as it flows by. But if you get damage to the endothelium, you lose that anti-thrombogenic property. So you're at risk of developing a clot in that area where there was damage. Make sense? The other thing is the endothelium has a second role, and it is a vasodilatory role. it is releasing nitric oxide to cause the layer underneath it, the smooth muscle layer, to expand and dilate the vessel. That's important for vessel mechanics, like when you're trying to recruit inflammatory mediators, when you're trying to control exudates or transudates. Okay, so you lose both of those functions when you have damage to that endothelial layer. What ends up resulting is you don't have endothelium that repair there. You get smooth muscle cells from this middle layer that move in and populate that tunica intima. So instead of having endothelium replace endothelium, you get smooth muscle cells replacing the endothelium. That's the pathology. It's not supposed to be that way, but that's what ends up happening. Smooth muscle cells migrate into the intima, and they proliferate. They mitotically divide. As they mitotically divide, they secrete new extracellular matrix. They cause that intimal layer to thicken, and therefore narrow the lumen, or the opening, as the inner lining gets thicker. These smooth muscle cells are actually not contractile. They don't behave like the smooth muscle cells they came from when they move into the intimal layer. They actually are non-functional smooth muscle cells. So this picture at the bottom is showing this disease progression from the left side to the right. So you can kind of appreciate, this is our internal elastic lamina, so that's this border right here. And down here are smooth muscle cells. You can see these guys are migrating in because this is normal endothelium, and as you move to the right, you're getting damaged endothelium, and it's getting thicker, and you're getting smooth muscle cells that move in here, and they are not contractile, non-functioning, but they make new extracellular matrix. And as that layer thickens, the lumen, or the opening, gets smaller and smaller. Make sense? So that is vessel disease. Vessel disease. Okay? If we categorize this broadly, we call it arteriosclerosis. Arteriosclerosis is a word that refers to smooth muscle cells and collagen fibers migrating into that tissue, into the tunica intima. It's an abnormal thickening and hardening of that layer. The tunica intima thickens. It's not contractile, it hardens. The lumen, or the opening, gets smaller. So arteriosclerosis, vessel hardening, that's what it literally translates to. Vessel hardening. Sclerosis is a hardening. So vessel hardening. Now we got two different types of arteriosclerosis. And this is where students get a little mixed up. Okay? Arteriosclerosis is a broad category. Underneath that we have two types. We've got arteriolosclerosis that really targets the small arteries and the arterioles. And it's very closely associated with hypertension. Arteriolosclerosis. Okay, so look at the spelling here. Arteriolosclerosis. And then we have athero, A-T-H instead of arterial. A-T-H, atherosclerosis, abbreviated A-S. And this is where you get a gruel or an atheroma. You get debris. You have muck. Okay? Any word that you need to help you remember that you get some sort of garbage forming there that's different than just smooth muscle cells making extracellular matrix. Okay? When you have an atheroma with atherosclerosis, this happens to be the most common type of arteriosclerosis and the one you usually hear about. These two terms are typically used interchangeably, although it would be incorrect to use them interchangeably. Atherosclerosis is the most common type of arteriosclerosis, but arteriosclerosis is the broader category. Okay? Athero, or AS, is where you get this lesion, or this gruel, or this tissue trauma that has an inflammatory event that we're going to talk about. So in the atheroma that takes place, you can see this picture looks extremely different than this picture. This picture is showing this atheroma that's formed right here, where you've got a necrotic core. You've got a fibrous cap that's like a fibrous capsule. Right? You have a chronic inflammatory event that's happening in the wall of the blood vessel. Okay? Atherosclerosis, where we've got smooth muscle cells that have moved in, like what we saw with just the general category of arteriosclerosis. But now we're actually recruiting macrophages in here to battle this inflammatory event. Those macrophages actually are gobbling up depositions of fat and cholesterol that form in this particular area. As they gobble up the fat, the lipid, and even calcium depositions, they become what are called foam cells. Those are these macrophages that have basically phagocytosed cholesterol and fat, and they turn into what we call foam cells, and they just sit there. Question here, and then question here.
So when you said that the endothelial cells are damaged, the
Antithrombogenic?
thrombogenic agent is lost, so it can clot. Does that mean they can form aneurysms then? And would that be a cause of arteriosclerosis?
No, so it wouldn't necessarily lead to an aneurysm because they lost their antithrombogenic properties, but they would be susceptible to a thrombus. And so if that was happening in the blood flow of the heart, and you get a thrombotic occlusion, now you're going to lead to a heart attack. Okay? If this happens in the brain, and you have not the thrombus necessarily, but if you form a clot in the brain, you lead to a stroke. But if you have this right here that persists, and it becomes weak, and it fractures, now you can have an aneurysm. Okay? You with me?
So is it normal for smooth muscles to go into the artery instead of the endothelial cells?
No, it's not.
So what makes it happen?
The damage. So the endothelium in vivo are not designed to replenish themselves post-damage.
So if I injure myself, does that mean that muscle cell is going to go to my endothelium cell?
So as you age, you lose the endothelial cells. As you age, lose their ability to heal. When we're younger, it does it just fine. When you're older, the chances of endothelium repairing are lower, and the smooth muscle cells have a greater longevity, and so they're more likely to be available. That's why an atherosclerotic disease isn't necessarily a disease of a 12-year-old. It's of like a 72-year-old. Right? So remember, age is a pathology. So as we get older, our endothelium stop behaving the way they're supposed to behave. So we see this in tissue culture, right? You know, Oscar's there, he's grown some of these cell types. When we grow cells outside the body in the laboratory, they will divide only so many times before they get kind of too old to remember how to do it correctly. Then they start behaving weirdly, right? We have odd cell morphology. So it gets accelerated, the pathology gets accelerated when we pull them out of the body. But cells have a definitive lifespan. They won't live forever, unless they're a cancer cell, right? And then they're immortalized. Okay, good question. These are really good questions. This is why I shortened the slide deck, because I wanted to make sure that we could pause. You guys like to ask questions of notes, more so than some of my other classes, which is great. So we just adapted, right? We just leave more time for questions. Okay, so the pathogenesis of AS, atherosclerosis, right? Athero. It's a multiple step process. There's an ongoing inflammatory response to chronic injury. I'll talk about what's the injury, right? Like, what am I, like, slapping my arm all day? Well, kind of, but maybe from the inside. I'll explain. And so you have this chronic injurious stimuli to the endothelium. They lose their normal function. They're not antithrombogenic. They're not able to release nitric oxide, have vasodilatory properties. And now you get fat in the form of lipoprotein that's accumulating. So if you look at the very top of this slide, you can see what are some of the things that are going to stimulate chronic endothelial injury. Well, think of stuff that's on the inside environment of the bloodstream. So if you have a high fat diet and you're hyperlipidemia Now the blood isn't flowing with a low viscosity. It's got a high fat content. So it's a rougher interface between the blood and the endothelium. So hyperlipidemia causes endothelial cell injury. That's why we don't want our patients to have high fat and high cholesterol in their bloodstream. Make sense? It's bad for the endothelial cells. Hypertension, back to the beginning of the lecture. High blood pressure. It's going to cause excessive pressure that the endothelium are going to feel and see, and that's going to cause trauma. Now think about this, not over 12 years. The 12-year-olds don't suffer with this, right? Like just the other day, my daughter asked me, I made a pot of soup, right? I made a pot of soup. We had chicken dinner, and there's like extra chicken carcass. I'm a cheapskate, so like, don't throw away the carcass, I'll make soup, right? So I made soup, and it was snowy, and we had like soup and sandwiches, and it was great. But I didn't add enough salt, and so she went like this with the salt shaker. Like the one with the pour mechanism, right? And it was like, shh. And I'm like, hey, that's a lot. She's like, you think that's too much? I was like, I don't know, you're trying. She's like, well, is it bad for you? And I was getting ready for this lecture. I'm like, you're 16, so go for it, sweetie. I mean, you're gonna be fine. You know, by the time you have an issue with it, I'll be dead. So you know, don't worry about it. So this is an injury over hypertension or hyperlipidemia for like 12 or 16 years. We're talking like 70 years. Okay? Chronic. Smoking. There's a lot of bad stuff in cigarette smoke. Okay? There's still bad stuff in vape products. We just don't know all the effects of it because it's brand new. Okay? If you absorb it, it gets in your bloodstream. Can it alter the flow and shape and hemodynamics of your blood? Yeah, possibly. Could that be bad to the endothelium? Yeah, possibly. Okay, bless you. Viruses and toxins, right? Hemodynamic factors, which are a little uniquely different than hypertension, but hemodynamic factors could be just abnormal flow disturbances. Okay, you've got abnormal flow disturbances. The blood flow isn't necessarily laminar. Laminar is a term that means very smooth blood flow. If you get very turbulent blood flow because you have hemodynamic disturbances, then you can start disrupting the endothelium. But then this leads to endothelial cell dysfunction, right? You increase the permeability, you get more monocytes adhering and moving out, you recruit more macrophages and you activate them, right? And this is happening within the wall of the blood vessel. So as this continues, right, we get the progress of what we know as the inflammatory cascade. Monocytes move out, turn into tissue macrophages. They can make free radicals. The low-density lipoproteins, these are oxidized, right? They're oxidized, and when they become oxidized, now they stay in location. They're not going to move until the macrophage comes and tries to chew it up, and that forms a foam cell. And that foam cell just stays in there. Now you've got this beginning of this atheroma. You get platelet adhesion because you've lost your endothelial lining that's anti-thrombogenic. You recruit these smooth muscle cells like we talked about in the beginning. They make their extracellular matrix, and they continue to proliferate and narrow that lumen. And the fat continues to accumulate in that lesion. So you get what's called a fatty streak, right? Smooth muscle cells migrate over top. You get a plaque that forms. The C-reactive protein that forms in that plaque, that's a trigger to stimulate more of the inflammatory cascade, the C-reactive protein. That's why we get the term reactive. That plaque that forms, that lesion that forms, is a fibrotic scar as a result of a healing response that doesn't return function to the blood vessel. Now, to the question that was asked, who was it? Ollie, right? Asked this question. So, well, you kind of asked this question. Stable versus unstable. If this plaque that forms is stable, that means that we're not worried about it fracturing. But if it's unstable, we're actually worried about it rupturing and maybe forming an aneurysm, or the patient could essentially bleed out. So I'll show you this here, and I'll touch on this a little bit more here in a few slides, but let me just walk you through all of the things that are happening, then we'll get to your question. Okay? So here's our internal elastic lamina. This is our benchmark. Remember, this is dividing the tunica media from the tunica intima. And so everything up here should be a single cell layer of endothelium, and you can see that it's much thicker than that. But what's happening is you progress from left to right, the disease is getting more aggressive on the right side, and it's just getting started on the left. The low-density lipoprotein moves in from the bloodstream, it becomes oxidized, and the macrophages take it up and form these foam cells like we talked about. You get extravasation of monocytes becoming these macrophages, right? This is the recruitment pathway that we learned about in the very beginning of the semester. You've got cholesterol moving out because the endothelial cells now are super leaky and stuff can just move into the intimal layer. You've got smooth muscle cells from the medial layer migrating up and proliferating and releasing extracellular matrix. And so you've got all of this crap, right, is the scientific term, happening, or atheroma really is the scientific term, or gruel, that's the AS, that's the atherosclerosis, which is a form, the most common form of arteriosclerosis. Okay?
So the macrophages are attacking the LDL.
Correct. Oxidized LDL. Oxidized LDL.
So they're oxidizing LDL.
No, they're already oxidized,
So they're
and then they get gobbled up. They probably get oxidized even more once they're inside the macrophages, right, through that respiratory burst mechanism. But the reason that they're stuck there and not moving is because they're already slightly oxidized. You get a very leaky vasculature, so you're getting some blood flowing in, and so there's oxygen available. So that's where the oxidation comes from. Okay, it's in the presence of a high amount of oxygen. You know, the diffusion distance of oxygen is 250 microns in tissue. And so here, you're probably like 50 microns. So from the bloodstream, oxygen is easily able to penetrate. Until this gets too thick and it becomes necrotic. Okay, and let me show you that. That's a perfect lead-in. This is what these tissues look like. Okay, overall architecture on the left. So you've got the L is the lumen. This is the lumen, this white space. This white space should be this entire circle, right? That should be the entire circle, L. All of this is disease. So when we look at this, if this is in the heart, in one of the coronary circulation, we would say that this vessel is maybe 30% open, 70% stenotic is the term, or closed. Some of you had a grandpa or grandma, they had an angiogram, they're like, yeah, I had 3 vessels and they're all like 90, 92, and 95% stenotic. That's more than this. That means that the circle that's open is very small. Not much blood flow is going through there. Okay. This F is the fibrous cap. The C is the necrotic core. And the reason this is necrotic is, look how far away it is from blood flow. It's way over here, so it goes necrotic. Okay. This is a zoom up of tissue right about here, okay? But it's stained with slightly different stains. And so now we're looking at the elastin stains in black, and the elastin stain right here is the internal elastic lamina. So you can appreciate from the cartoon drawings that the lumen should be right on the other side of this black stain. Does that make sense? Now, all of us, as we get older, are going to have some amount of deposition in our vessels. There isn't a 70 or 80-year-old patient that's healthy vascularly that doesn't have slight arteriosclerosis. Okay? You open it up and you look at it and it's going to be slightly narrow. But this is pretty aggressive. Okay, that's pretty aggressive. And this is a disease that happens all over the body, not just the heart, it happens everywhere. The heart and the brain are especially susceptible because they're high uses of blood flow. Okay, so then on the far right, under C, in a higher magnification view, some of the features I want to point out. The arrowheads are pointing to areas of calcification, and the arrows themselves are showing new vascularization. So two things that are kind of interesting that happen is the arrows versus the arrowheads. So this is a calcified lesion right here, calcified lesion. It's like stone. That makes these arteriosclerotic lesions crunchy or hard. That's where it gets its terminology, hardening of the vessel. And then the arrows themselves are showing new blood vessels that are growing inside of this diseased tissue because it's trying to revascularize itself so it doesn't go necrotic, like this necrotic seed area. Okay, kind of weird. What's the outcome that could happen? Well, to the point that was brought up earlier, this is kind of how this matures. We've got the preclinical phase, right? Usually at a younger age. All of us have choices that we make about our diet. And so if we choose a very Western influenced diet that's pretty high in polysaturated fats, we're going to be developing some amount of fattiness in the preclinical phase. At some point, we're going to reach a place where we call vulnerable plaque. And if it's a vulnerable plaque and it is unstable, right, we could either have it rupture and cause an aneurysm, right, which is what you brought up earlier. It could get occluded by a thrombus, right? So blood with that narrowing, like we saw in this previous picture, right now is a smaller opening, so it's much easier for blood to clot in a smaller opening and form a thrombus and occlude it. Or it could just continue to narrow off and go to critical stenosis. And so in either one of these phases, you're going to get some outcome of ischemic heart disease as a response, which, if it's left unchecked and unattended, could progress to congestive heart failure. Okay? So, last little section for today, ischemic heart disease. And we'll kind of bring it back to chronic heart failure, but this is a balance between perfusion and demand, or blood flow and blood need or usage. The most common cause of ischemic heart disease is atherosclerosis, the gruel, the narrowing of the vessels. And this formula of cardiac output equals heart rate times ejection fraction is important to keep in mind. Cardiac output is the amount of blood that the heart can produce per minute. Okay? It's usually in liters per minute or milliliters per minute. Heart rate's in beats per minute. An ejection fraction, right, is the amount of blood that's actually pushed out of the blood, or the efficiency of the heart as a pump. So, clinical manifestations of ischemic heart disease: chest pain, angina pectoris, right? Angina is a word that literally translates as a strangling feeling in the chest. Acute myocardial infarction, otherwise known as a heart attack. Chronic ischemic heart disease, long-term heart disease, or sudden cardiac death. It can go ischemic and a patient may not even survive that. If it's chronic ischemic heart disease, this could lead to heart failure. This you can put here, could lead, if it progresses, to CHF, chronic heart failure. So if we look at angina, we got kind of three different types of angina. This is a term that you'll hear a lot. Strangling feeling in the chest is how it literally translates. We've got stable angina, Prinzmetal, or unstable. Stable angina is referring to pain upon exertion. This is the most common type. So the way this usually manifests itself is the patient says, when I climb the stairs, I feel like I have chest pain. But when I'm sitting on the couch eating my potato chips, I'm fine. So I just sit on the couch and eat my potato chips. Okay? Prinzmetal, this is pain on rest or at night. So even sitting on the couch eating potato chips, there's pain. It's also referred to as variable angina, but Prinzmetal. And then unstable angina. Unstable angina, also known as crescendo. Those magicians in the room, crescendo means what? What does it translate to? Getting louder or getting bigger, okay? So unstable angina is, you've got over a 3 to 4 day period of time, the pain worsens and increases. Now, usually this will present like the patient said they had something that took place on Friday, but by like Sunday, they went to the emergency department because it got worse. Okay, that's crescendo or unstable angina. If we look at myocardial infarction and we look at the vessels that perfuse the heart, we can see that there's a natural architecture of how this is going to spread. Okay, so acute myocardial infarction is the early phases of a heart attack. Okay, the patient has chest pain, they go to the emergency department, maybe they get a angiogram, and they go straight to the cath lab and they get treated. So the vessel, this is the left anterior descending vessel, and you can see here's the blockage. Right? That could be a thrombus, or it could be a lesion that continued to close off. The distal or downstream tissue here that's blanched is the area that's at risk. That's the area that's not going to get blood flow, the downstream area. So the myocytes down here can last about 20 minutes without blood flow, and then they start to die. Once they die, they become ischemic, they're no longer viable. But as the wave spreads, this is a cross-section. This is the inside of here. So this is the endocardium. This is the myocardium, and this is the epicardium. And then here is the vessel that's sitting on the epicardial surface, but it perfuses distally as it dives deep into the tissue. So at the 0-hour time frame, when it's going from 0 to 2 hours, the endocardial area is the first area that becomes necrotic. And then it goes from endocardial to transmural, all the way through the entire thickness of the myocardium. That's an acute myocardial infarction. Now, we can keep track of how old we think the lesion is. We can do that by taking blood. And this is our last slide. So if we take a blood draw from a patient and we know there's a heart attack, right, we can see on, oh man, this is horrible. I hate this screen. I don't know why. Or I guess I hate something. I hate that. Yeah. I love all of you. I just don't like it. This should be up here, but what you can see is, do you see the through and through lesion right here? This dark part is transmural all the way through. Okay? When that disease happens, we can actually take a blood draw and we can look at TNI levels and TNT levels. These are troponin I and troponin T. If you remember back to 201 and 202 when you talk about cardiac. But 201 and 202, you're talking about cardiac muscle. Troponin is part of the architecture of the way that actin and myosin are going to interact. You guys remember that with cross-bridge formation? So if you get damage to the myocardial tissue, you leak troponin into the bloodstream, TNI and TNT. It usually peaks 2 to 4 hours. It appears, it shows up 2 to 4 hours after the infarct, and it peaks at about 48 hours, and it remains elevated for a week to 10 days. That's TNI and TNT, the first two. CKMB, creatine kinase myocardial bound. This rises within the first 2 to 4 hours. It peaks at 24 to 48, but it's gone by 72 hours. And then lactic dehydrogenase, LDH, right? This one has a very similar profile as CKMB, right? So same 2 to 4 hours, it shows up, peaks at 24 to 48, it's gone by 72 hours. Those two, creatine kinase and lactic dehydrogenase, those tell you that the heart is switching to non-aerobic mechanisms to generate energy. And that's why those lactic dehydrogenase is an enzyme that helps to manage lactic acid breakdown from glycolytic pathways. Okay, so if you get elevation of alternative fuel sources, you know that the heart is not able to utilize normal aerobic mechanisms of energy. Okay? Questions? So please look at the modified slides in your notes for liver as well as cardiovascular or heart diseases, because that's what's going to be testable in the new material. And with that, we conclude our lectures for the semester. You guys have a great week, okay? I have office hours on Monday. Fine. Yeah, I'll be here for that. Okay. Yeah, not show up.